Before we get started on the rest of the review for the final exam, I thought I'd show you something that might help you to understand why it is that we do things the way we do. So these are the exam results from the ART from 2002. You can see the graduation exam dates for August 2002. So the registry is cut up into different sections that you can see down here at the bottom. We've got patient interactions and management. We've got radiation physics and radiobiology, radiation protection, image acquisition and evaluation, equipment operation, and quality assurance, including quality control, head, spine, pelvis procedures, thorax, abdomen procedures, and extremity work. So you've got 8 different sections, and we kind of divide it up between physics, rad bio, patient care, imaging, and positioning. So really, we group them into 5 sections. And the variable that is always changing is image acquisition and evaluation. So if we look at our scaled results, so what we have are the 8 sections across here, and our overall scores on each one of those sections are reflected down here. So the 2 portions that are where we score consistently the lowest would be in image acquisition and evaluation, image production, which is what we're going through this semester in imaging. And the reason it's so confusing and difficult, and the reason that we tend to score low on it is because it's always changing, is number one. But also some of the concepts that we have to cover and talk about, you don't really see in clinical practice, like the concepts of KVP and the effects of KVP on the image. We used to have to cover extensively, but really KVP doesn't affect your image all that much anymore. As long as you get to the point of penetration, you use adequate KVP. There's a variance. Increasing or decreasing your KVP by 10% is really not going to change the appearance of the image. In addition, we talk about overexposure and underexposure using both KVP or mass. But the only indication that you have for over or underexposure has become the index number and not the appearance of the image at all. So it's difficult for students to make that transition from what we talk about in class to the clinical reality being that what we do at the control panel doesn't affect the end result image as much as what it used to. Still extremely valid in patient dose, but the appearance of the image, you really have to mess up with your KVP and your mass to get an end result on the image that would cause you to repeat the exam. So it's difficult. It's hard to grasp, and our scores being consistently the lowest in that section are indicative of that. That being said, our average was 8.8, which equates to an 88 on the registry in that section. The other portions that are difficult to get and are reflective on the registry are not surprising either, and that would be your general physics. So the physics X-ray creation, and this result in radiobiology and the equipment maintenance and operation, which is a first semester physics class that we talk about, or that our radiographic imaging or radiographic equipment class in our first semester, that first physics class. So those 3 sections are consistently the lowest, but again, the lowest of the 3 is imaging, and it's 8.8, equates to an 88. So the reason we go through that class 4 different times in 3 different semesters is for that reason. It's hard to grasp, it's hard to wrap your mind around, and it even all the way through the registry, and after we talk about it 4 separate times, it's still hard. So the other thing that I wanted to show you is what we're going to be talking about in your sophomore year on quality control. So this is a Word document, but there is a PowerPoint for this as well. Quality control, we have to maintain quality control on all aspects of our imaging equipment. So we talked about timers and MA stations. MA stations, the quality control for MA stations, linearity. And we're going to talk about what all this stuff means in your sophomore year. MR to MAS output is what I was mentioning in class today. It's kind of like linearity between 2 rooms with the like generators. Reproducibility is the ability of the machine to make the exact same exposure over and over and over again with the same kVp and mass, but we'll get to that. We have to evaluate our automatic exposures and whether or not they recreate the same exposure with the same absorber. Our kVp, we talked about that, and this has 2 to 4 kVp, but that's been dialed into consistently being taught at a 5 kVp variance half value layer. You know the half value layer changes over time because of tanning of the X-ray tube. Our distance indicators, we have to make sure that if our machine is showing us to be making an exposure at 40 inches, it truly is 40 inches. Centering indicators, and whether or not we have good alignment. Light field and collimators, all these are done all at the same time, but the light field may shift because the mirror may be knocked off of that 45-degree angle. So if it's at a 45-degree angle because of rough handling, sometimes it slips a little bit, and our light field will be in a different place compared to our radiation field, giving our collimators an appearance of being inaccurate. We'll talk about all that. Vertical beam alignment, making sure that our X-ray beam is truly perpendicular. Focal spot size, we mentioned that in class today. Remember, the smaller the focal spot size, the larger the variances that we have. So if they're smaller than 0.8 millimeters, then a 50% increase in size of our focal spot compared to what the manufacturer said our focal spot size is allowed. In other words, at 0.8%, 50% increase is half. So our allowed focal spot size, actual focal spot size, could be 1.2. And the larger they get, the less allowance there is. So at 1.5 millimeters, there's just a 30% change. So we're going to talk about the ways we can test all this. Some of this stuff has changed from this document. It's just easier to scroll through this. So image receptors, this is obviously old, but that would include grids. But cassettes, that's a screen film issue. Fluoroscopy, we have to have specific reproducibility and SID on that. So we got a lot of stuff that we've got to look at in our, it's just kind of a cheat sheet type thing, but we have a lot of stuff that we have to look at in quality control and make sure that our machine is shooting accurately. So then we'll get back to the topical review, and I just wanted to show you that. So we made it through filtration. We're going to pick up with grids. The purpose for the grid is to absorb scatter radiation after it's been created. So it absorbs wide-angle scatter radiation. That is your Compton. Thomson may be unaffected, but remember, Thomson radiation is it accounts for a very small portion of our remnant beam. So it removes it after it's been created, meaning the remnant beam or the secondary radiation. Use of a grid is going to increase patient dose dramatically. Remember, our grid factor, our Bucky factor is going to be, depending on your grid ratio, anywhere from 2 for very low ratio grids, 2 times the mass, all the way up to 6 times the mass for very high ratio grids. So just the presence of the grid doesn't necessarily increase the dose, but what we have to do is we have to increase mass to compensate for the grid use, and that's what increases the dose. So grid, as grid ratio increases, if we go from non-grid to a low ratio grid, we have to increase mass, which is naturally going to increase patient dose. If we change our grid ratio from a low ratio grid to a higher ratio grid, then again it's going to increase. A Bucky factor is going to increase. So we're going to increase our mass, and patient dose is going to increase. It's going to increase maybe a little bit with grid frequency, but grid ratio is really going to be the determiner of how much of a change we're going to have. So it doesn't decrease scatter production. It decreases scatter that will be incident on the image receptor. It cleans up the scatter after it's been created. So the types of grid, the hazards, I guess hazard's a bad name, but the causes for grid cutoff on each one, you have to know each one. So the benefits of a parallel grid, which is the benefits of parallel grid is that they're easy to construct and they're cheap to construct. The application or how you can use them is there's more flexibility. There is no set distance that you can have with a parallel grid. The downside or the hazard, so to speak, is that you're always going to have grid cutoff in the periphery, and it's going to get worse at low SIDs. But still, they say that the focus is infinite, or the range is infinite. You can use them at any distance. Then you've got your focus grids, and focus grids, you don't have the grid cutoff in the peripheries, the benefit, but they're harder to construct because they have to, the canting of the grid strips have to be very precise. And then your SID can only be used at specific distances, or you can only use them at specific SIDs. And if you exceed that distance, that being the focal range, and if you exceed that focal range, if you come in too close or get too far out, then you're going to start to have grid cutoff in the periphery. Also, if you have your grid inverted, flipped upside down, then you're going to have some very significant grid cutoff in the periphery, and the only place that you're going to have good density is right down the middle. You don't have that problem with a parallel grid. You can flip it around either way. It doesn't really matter. So then you've got a cross grid. So you can have two different types of cross grid. One's pretty rare, but a parallel cross grid is kind of like you've taken two grids and you stacked them on top of each other with grid lines or grid strips going perpendicular to each other. So the benefit there is that you've got very good cleanup. With a parallel grid, you can still have scattered photons that go that will make it through the grid as long as they're going parallel to the grid. With a crosshatch or a cross grid, that's not going to happen. They're going to be absorbed regardless of which way they go. The benefit of the focus grid and the parallel grid is you can angle parallel to the grid strips. So the grid strips are oriented in your Bucky with the long axis of the Bucky so that you can use an angulation. So think, since we did skull work this semester, think of a town. So you can angle with the long axis of the table, long axis of the grid, long axis of the grid strips, and you're okay. You just can't angle across the table. With a cross hatch grid, you can't angle in any direction. You have to be perpendicular. The less common of those is a focus crosshatch grid. So if you had a parallel crosshatch grid, you could off-center anywhere on that grid. But if you have a focus crosshatch grid, then your central ray is going to have to be right dead square to the center of that grid. Otherwise, you're going to have grid cut off in any direction. So, which one has the best cleanup, contrast improvement factor? That would be your crosshatch, focus crosshatch specifically. Which one has the least chance of grid cutoff? That would be parallel. Which one has the greatest, and which one has least positioning latitude? So you have greatest positioning latitude with parallel. Then after that, your positioning latitude with a focus, and then after that, positioning latitude. The least positioning latitude would be with a crosshatch, and specifically a focus crosshatch. So what theoretically, anytime that you have a grid, not theoretically, but actually, you're going to absorb not just the scatter radiation, but you're going to absorb some of the primary beam as well. So if you look closely enough, if you magnify it up enough, you might be able to see the grid strips. So what a moving Bucky does is it blurs out those grid strips. So it moves back and forth, or it moves around in a circle. That would be reciprocating back and forth and oscillating in a circle. Those are your two types of motion. So if you have that motion going on, then it works kind of like a breathing technique for lateral T-spine. The lung markings and the ribs are moving a little bit, so it kind of blurs them out. And with that movement of the grid, you also get a blurring of the grid strips, so you just don't see them. If you have a failure of the mechanism that causes the motion, then again, you're back to a stationary grid, and you're not going to have the benefit of that motion. You could introduce again the grid strips, the visualization of the grid strips. So causes for grid cutoff, I already talked about. Type of photons that pass through the grid would be those that are unattenuated, so your transmitted X-rays. Primarily, you're going to get some scatter through, but that would be scatter that parallels grid strips, or your Thomson classical scattering photons. So cleanup, the higher the ratio of grid, the higher the cleanup, the better the contrast improvement factor, the better the cleanup. Those will be with your higher ratio grids. Your higher ratio grids are going to give you better scatter cleanup. So make sure that you can work grid ratio problems and identify the description of what grid ratio is. Grid ratio, again, I think I put this in the last video. Grid ratio is the height of the grid strips divided by the distance in between them. We'll see contrast improvement factor, which is also K factor, always has to be greater than 1. If your contrast improvement factor is 1, that basically means you have no grid. So as grid ratio increases, your contrast improvement factor increases. So if you had a grid that had a contrast improvement factor of 1.5, and you were comparing it to a grid that had a contrast improvement factor of 2, then what that would tell you is the one with 2 is a higher ratio grid with better cleanup. So your Bucky factor will be given to you on the test. That is your grid factor. That is how much of a change in mass you will need to compensate for the presence of a grid or the increase in grid ratio. So you always compensate with a grid for a grid with mass, and your patient dose and grid use is always going to be higher with a grid than without. So as grid ratio increases, I've already walked through this, but as grid ratio increases, your patient dose increases as well. So then we'll get to patient factors. What type of tissues are more likely to cause photoelectric interactions? That would be bone, something with a high ZEF number, Z effective number, higher effective atomic number like bone. And anything that is more similar to water is going to create more Compton interaction. Take 4. K-edge absorption is the likelihood that a tissue will absorb X-rays. So that inner shell binding energy, the higher the inner shell binding energy of the tissue type, the more likely it is to absorb X-rays. So again, the types of tissues that have the highest K-edge absorption would be tissue types with high atomic numbers, minerals, bone. So bone has higher KH absorption. So absorption blur is a little bit hard to wrap your mind around. So absorption blur is the characteristics of the anatomy that will cause you to lose not just sharpness or recorded detail, but the appearance of contrast as well, loss of contrast as well. So think of something, again, that's spherical, and because of the increase in OID on the periphery, on the thickest portion of the sphere, being elevated away from the image receptor, what you're going to have is a loss of sharpness or recorded detail on that edge. Now imagine if that structure was bone, or something sort of like bone, like the head of the femur, the head of the humerus, something like that. So you got a spherical thing that you're going to lose some sharpness or recorded detail in the periphery because it's spherical, and you've got an increase in OID. But since it's bone, it should have very high contrast, but there at the edges where you've lost that sharpness or recorded detail, what you're going to have is the appearance of loss of contrast. And radiographically, it will be a loss of contrast. But not really because you've lost density. So it almost flies in the face of K-edge absorption. You still have a K-edge absorption, but because of the loss of sharpness or recorded detail right at that surface, at the outer surface, you're going to look like you've lost contrast, where in fact you did not. And that's what we refer to as absorption blur. So Buchong talks about it on page 288, but he doesn't really necessarily call it absorption blur in the description itself, but that's what it is under object shape. What shapes of structures affect distortion the most, and that again would be spherical, because you just can't compensate for it. But any structure that does not follow the divergence of the central ray, that you can't put in a way that's parallel to the image receptor and perpendicular to the central ray, is going to give you distortion. But spherical would be the answer to that question. All right, so what type of interaction increases when tissue thickness increases? Most of the time what you're going to get is more scatter radiation. As thickness increases, that's usually going to be adipose tissue or soft tissue, and what we're going to get more of there is going to be scatter production. Now we're going to do image receptor response. So a lot of this is going to be repeated from earlier in the review, or possibly part one. So be able to identify what long scale means. Long scale means low contrast. You've got a lot of shades of gray. So if just word association, long, if you had individual, sections of something colored differently, if you only had two, that would be a short scale contrast. It'd just be 1, 2, as opposed to if you had a lot of different shades of gray, then it would be a long scale contrast. So long scale contrast means low contrast. Short scale means high contrast. Long scale contrast, low contrast, also means high latitude. So image receptor exposure is controlled by mass primarily, is what we use to control image receptor exposure. Remembering that a 30% increase is the minimum amount that we would change our mass in order to affect any kind of change, to move the needle even the slightest amount. But 30% increase is not going to do anything significant for you. If you made an exposure and showed 30% too little exposure, you would never repeat that exam just to increase by 30%. So the minimum that you would use in order to make a repeat is a change by a factor of 2. So it'd be a 100% increase or a 50% decrease. Both of those would be a change by a factor of 2. So anytime that you want to repeat an image, your starting point is a factor of 2. Now, something we haven't talked about, and Amy might have talked about in the first semester, is that your image receptor exposure is going to be proportional to your index number in some way. Some of your index numbers, as image receptor exposure increases, your index number is going to decrease. So that's an inverse relationship. But there should be some proportionality that makes sense. Like, for example, if you made a exposure and you got an index number of 400, if you doubled your exposure, it should drop your index number in half. So in a system where if you increase exposure, your index number goes down, that should be your relationship and your proportionality. So factor of 2 in both cases. Some of your index numbers will go up whenever you increase your exposure. In my personal opinion, there should be some sort of industry standard on that, but there is not yet. So double or change by a factor of 2. So with mass, there's a direct relationship between image receptor exposure, not necessarily the index number, but image receptor exposure. Meaning that if you increase mass by 10%, your image receptor exposure can be expected to go up by 10%. If you increase your mass by 200 times, then your image receptor exposure will go up by 200 times. So again, that doesn't mean that that's the direction your index number is going to go. It just means that the image receptor exposure, the actual exposure to the image receptor, is going to change in direct proportion to your change in mass. So as you increase mass, you increase image receptor exposure. Contrast is really controlled by your lookup table. KVP and mass don't really have any part or much of a part in your contrast. Your lookup table is primarily what's going to control that. There might be a little bit of a change, but unless you took two images with different KVPs and masses that you could compare side by side, you're not going to be able to tell much of a difference at all. So contrast and density are really controlled by that lookup table. That's the computer algorithm, processing algorithm is what we call a lookup table in CR and DR. Some other things can control your contrast and especially your density. Collimation being one. Our collimation, if you leave your collimation open very wide, then what you're going to have is an area on the image receptor and on the image eventually that is really dark because of direct radiation exposure. So as your computer is trying to process all that excessive density, you can expect to see a few things. One of which is that it's going to show, even if you use the perfect exposure, your index number is going to be too high. So we use the index number as a visual of whether or not we got adequate exposure, but there are other things that go into the formulation of that index number, including direct exposure, areas of extreme darkness on the image. So as your computer's trying to adjust to all that direct exposure, it may affect your contrast. Certainly it will affect your density, but it may affect your contrast as well. Scatter radiation can affect your contrast as well. So if the computer compares the lookup table to your histogram and it can't really make sense of what it's seeing, then what you get is what we refer to as a automatic rescaling error. So the process of comparing your histogram to the lookup table and trying to make them match up is what we call automatic rescaling. So if we have an automatic rescaling error, it means your computer can't figure out what you did, and your contrast and density may suffer in that case. So your H&D curve, we talked about the H&D curve, and it doesn't really have a place except for visuals for what your lookup tables, the type of lookup tables that you are going to apply to your image. So just a real quick, brief review of that. If we have an H&D curve that's very horizontal, that means that it takes a lot of exposure to go from one density to the other. Long scale contrast, low contrast. Very horizontal lookup table or H&D curve is associated with a lookup table that's going to give you a lot of grayscales, as opposed to a very vertical lookup table or very vertical H&D curve is associated with a lookup table that will give you very high contrast. Okay, so histogram analysis failure is what I was referring to a second ago as a automatic rescaling error. Really same thing. So I've got in here that's secondarily controlled by the KVP, but that's because of two things really. With your KVP, you can change differential absorption inside the patient's body, and if you got into the extreme, let's say you shot a hand with 100 KVP, you might be able to see a little bit of a difference. Or if you used 120 KVP for KUB because of the scatter creation, you might see a little bit of a difference, but you're not really going to see within reasonable ranges. You're just not going to see a whole lot of change in your contrast using KVP. So we're going to use KVP to affect a change in image receptor exposure only under certain circumstances. So if we need to increase penetration, like if we're doing a barium study, then we need the higher KVP to try to penetrate through a portion of the barium. If you use low KVP, then it's going to try to compensate with an increase in mass, and you know that you can't compensate with a lack of KVP with an increase in mass. So the only thing that you get there is a drastic increase in patient dose. So if you need to increase penetration because of the tissue type that you're trying to put the X-ray beam through, you may want to increase your KVP. So tissue composition as well. If it's thicker but has a density more like bone, if you have a patient who has acromegaly is giantism, leads to giantism, or osteopetrosis, where we've got a buildup of extra bone or more bone than what we should have, then we might need to increase KVP. Otherwise, again, we're going to have a situation where your phototimer is going to try to add as much mass as it can to try to get to a reasonable exposure. It's going to just increase patient's dose. So changes in KVP are going to have a direct impact on image receptor exposure, but the proportionality is going to be exponential. So a 15% increase in KVP is going to give you the same amount of change of image receptor exposure as a doubling of the mass. So if you increase your KVP by 15%, you get doubling of the image receptor exposure. If you increase by 5%, that equates to 30%. Increase of 15% equals a 100% change. 5% increase is a minimum that you would use for to affect just even the smallest amount of change at your image receptor. So again, you would never repeat just for a change of 5 kVp. So image is worth repeating for an increase in image receptor exposure using KVP. You start at 15%. So just like in mass, you would double your mass. With KVP, you would use 15% increase in KVP, and that would give you a doubling of the image receptor exposure. So the other times that you would use a change in KVP to affect image receptor exposure is if you had a pregnant patient. So if you had a pregnant patient, you could use your 15% rule, increase KVP by 15% and cut your mass in half to save dose to the patient and save dose to the fetus. The other time would be in possibly in young kids. If you were shooting a KUB on a patient, especially a female patient, where you can't really shield, then okay. So let me run down a rabbit trail. A lot of people are talking about not shielding now. A lot of your professionals are talking about not shielding. So let's say in a situation where you would shield the patient, use contact shields, then with young patients, especially females, you would not be able to shield very well for KUB. So what we could use is an increase in KVP and a decrease in mass to arrive at the same image receptor exposure as what we would use with lower KVP and higher mass. If you're phototiming, you just increase your KVP and your mass will take care of itself. So the times that you would use KVP to affect the change at the image receptor exposure, or at the exposure at the image receptor, would be if you had an increase in patient density such that you needed to increase so that you can increase penetration. And the other would be pregnant patients or young patients, and that would be to reduce the patient dose. So with an increase in KVP, you get a higher average energy, you get more penetration. It pushes the brim spectrum towards a high energy side. It increases the height of the bubble, which means that we get an increase in numbers, a drastic increase in numbers, but especially at that higher energy range. So our differential absorption decreases. We get fewer PEs and we get more scatter in proportion to the photoelectrics. So other things that can affect image receptor exposure are things like collimation. So with collimation, what we get is a lower amount of tissue exposed. So beam restriction, and if you increase collimation, that means you reduce field size. So you reduce field size, you irradiate less tissue. So the area within the collimation should be the only portion of the patient's anatomy we're interested in seeing, right? But we're going to get scatter radiation outside of that field. As opposed to if we don't collimate, we're going to create not just densities over the entire image and through all anatomy, but also we're going to create more scatter radiation all the way across. So if you collimate, then essentially what you're eliminating is the not just the exposure, but some of that scatter radiation that would be created in the periphery would cover your area of collimation. So it's not just going to reduce the exposure outside of the collimated areas, but it's going to reduce the exposure in the area of interest as well. So how we compensate with that is with the increase in mass. So what we get is, and I kind of touched on this a minute ago, is if we don't collimate, we get direct exposure to the image receptor. Let's say we shoot a hand on an image receptor size that's 14 by 14. Then your computer tries to take all that extra density into consideration in a formulation of that lookup index number. And it's going to tell you overexpose a patient, even if you use the perfect technique. So tissue thickness, most of the time with tissue thickness, what we're talking about is, again, watery top tissues, so adipose. You might have some overdevelopment, some hypertrophy, buildup of muscle, or you may have edema or something like that. So what that's going to do is it's going to create a lot of scatter radiation. The scatter radiation is going to cover up the tissue of interest, and our contrast could potentially go down. Now, if we're talking about image receptor exposure, though, if you don't do anything with your technique, as that tissue thickness increases, your image receptor exposure will decrease. So we have to increase our techniques. Specifically, we have to use mass. If we add filtration, then what we're going to get is a more homogeneous X-ray beam. So it's going to push everything towards a high energy side. So we get an increase in average energy. We get a decrease in the lowest energy portion of the BREM spectrum. So we get a more homogeneous X-ray beam. We get a higher effective KV, and I intentionally left the P off of this because filtration does not affect the peak energy. So it's higher average effective KV, higher average energy, and it pushes everything towards the high energy side. Unfortunately, what we get with the increase in filtration, if we don't do anything to compensate for it, is we get a decrease in our emission from the X-ray tube. So this going back to the document that I showed you before on quality control, part of the reason that we have to do quality control every year is even if your KVP doesn't change, even if your KVP is solid, your mass in a room that's being used consistently, the amount of X-rays that are emitted from the X-ray tube are going to change because of tanning of the tube. So what we'll get is an increase in filtration because of the tanning of the tube, and that's going to give us lower output. So what we have to do, what Biomed has to do, is they have to get into the computer system or into the X-ray system and tweak it just a little bit to bring the output back up to where it should be. So in that context, filtration, keep in mind that if you add any filtration, it's going to absorb some of those low energy photons. Some of those photons might make it to the image receptor, and if they do make it to the image receptor, they expose it. It goes into the formulation of your index number. So as we increase filtration, the whole point to all that is as we increase filtration, you have to change your technique. So if you used a wedge filter, a compensating filter or something like that, you would have to change your technique. Specifically, you would want to increase your mass. So grid use, if you don't do anything with your technique and you add a grid, then what you're going to get is a absorption of scatter radiation. So some of the secondary beam that you want is going to be absorbed as well, but scatter radiation primarily. And scatter radiation lays down a layer of density, so it is a layer of density, it's just unwanted density. So if you remove that, then it's going to show, and if you don't do anything with your technique, if you just lift that scatter off, it's going to show that you're underexposed patient. So if you use a grid and you don't compensate for the use of the grid, then your image receptor exposure is going to decrease. So we've already talked about what you do with the grid. If you utilize a grid, you're going to have to increase something. Specifically, it's going to be mass. So scatter absorption increases more as grid ratio increases. So as we change from a 6-to-1 to an 8-to-1, it absorbs more scatter radiation and lifts more of that density. 8-to-1 to a 10-to-1, 12-to-1, 16-to-1, same thing happens. So image receptor exposure decreases with every increase in grid ratio. So it primarily reduces scatter reaching the image receptor, but we do have a little bit of absorption of the photons that we want. So grid frequency can affect the cleanup, but really grid ratio is the main thing that's going to affect it. So machine phase, remember that as we change from single phase to three phase, we get an increase in output from the X-ray tube. So if you shoot a perfect technique in a single phase room, and then you take that technique and that patient to a three phase room for a repeat, and you use the exact same technique, you're going to overexpose the patient, and you're going to overexpose the image receptor. So if you go from a single phase to three phase room, you have to decrease your technique by a factor of 2. If you go from a three-phase room to a single-phase room, you're going to have to increase your technique by a factor of 2. So machine phase, image receptor exposure decreases when changing from single-phase to three-phase and from three-phase to high frequency. That is exactly backwards. So I'll fix that. With machine phase, image receptor exposure increases when changing from single phase to three phase and then from three phase to high frequency. I think that the context of what I had there was your your technique needs to decrease if you go from single phase to three phase. So if you use the perfect technique in a single phase room and you change to a three phase room, then your image receptor exposure is going to increase. So you need to decrease your technique. And the same thing happens if you go from single phase to three phase room, high frequency room. So machine phases, we go from single phase to three phase, we get an increase in numbers, but it also pushes the BREM spectrum to the high energy side, so we have a higher energy X-ray beam. So KVP and mass can affect contrast in the extremes, but again, these are extreme exposure changes that you shouldn't be making these mistakes at this point in your education. Hands at 110 kVp, your feet at 300 mass or something like that. If you flood your image receptor with too much information and your image receptor can't really make any sense of it, then you're going to get, again, a histogram analysis error or histogram analysis failure, and it could affect your contrast. So way too much exposure to differentiate between different tissue types, or way too little exposure to differentiate. So as OID changes, this is your air gap, as OID changes, that's like lateral C-spine, then we get the wide angle scatter that would strike the image receptor is going to miss it because it's coming off at a wide angle. It's going to miss your image receptor. That's your air gap technique. So it misses the image receptor, and therefore with an increase in OID, you can have a decrease in image receptor exposure. SID, because I don't see that on here, SID, as we increase our SID, we're going to have a drastic decrease in image receptor exposure. So that's your inverse square law. As we increase our distance, our SID, we're going to have a decrease in image receptor exposure. And it's going to be square the change in distance. So if you go from 40 inches to 80 inches, then our image receptor exposure will decrease by a factor of 4. We doubled our distance from 20 to 40 inches, so 2 squared equals 4. So our image receptor exposure would decrease by a factor of 4. So your technique change would be the exact opposite of that. So if we change from 20 or from 40 to 80 inches, because we decrease our image receptor exposure by a factor of 4, we would need to increase our technique by a factor of 4. And again, that would be your direct square law. All right, so shape, we already talked about that in this video, and that would be that it may affect contrast, especially if you have like a round object because of your absorption blur. Collimation, we already talked about. Tissue thickness, we already talked about. Tissue density. As atomic number goes up, exposure goes down. So as thickness goes up, image receptor exposure goes down. So I want to point out one more time, I know I've mentioned this a couple of times in class, but you're going to have a tendency to think that, and it's a logical progression, but it just doesn't work the way some of you are going to think. All right, so as you increase thickness, you increase scatter. Scatter lays down a layer of density. So as you increase thickness, you create more scatter, you're going to create more density. So it's logical to a degree, but it doesn't take into consideration as you increase thickness. Yeah, you create more scatter radiation. A lot of that scatter is going to be absorbed inside of the patient, not make it to the image receptor. What comes through the patient is primarily going to be scatter radiation because of the increase in thickness. But if you don't change your technique and you increase thickness, then your image receptor exposure will decrease. So, though, if you have an increase in density, then it's not necessarily going to be scatter radiation that causes a decrease in image receptor exposure. It's going to be that atomic number. So you've got a density, you've got an atomic number that's much higher than it's going to absorb. You're going to have more photoelectrics, and your image receptor exposure is going to go down. So usually whenever we're talking about tissue thickness, it's going to be mass. Sometimes if we're talking about tissue density, it could also be mass. Like if we change our 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 tissue type from air, selected that specifically because the actual atomic number of air in soft tissue is very, very similar. It's just the concentration of the particles in the air, they're very spread out. So the overall density of soft tissue, even though the atomic number is the same, the compactness of soft tissue is much higher than what it is with air. So in that context, if we're changing from air to fluid, let's say, patient maybe has pleural effusion displacing some of the air, we would increase our mass to compensate. But you may use KVP in some cases if we have a higher concentration or density of bone. All right, so great differences in atomic number results in very high contrast image, and traditionally that's why it is that we use very high KVP for chest X-ray. Try to bring down some of that contrast and penetrate some of that, some of the bones that would otherwise stand out very, very well on traditional X-rays. But with a computer algorithm, you could shoot a chest X-ray with 60 kVp and still make it look like a chest X-ray. Don't recommend that. Patient dose goes up, so continue to use your high kVp for chest X-rays. So filtration, we already talked about. As filtration goes up, exposure goes down, image receptor exposure goes down because you lose more photons. Patient exposure goes down, but image receptor exposure goes down. So grid use. Okay, so again, we're hitting the redundancy phase again. Our exposure is going to decrease with grid use. Patient exposure is going to increase because you have to increase your mass. Exposure decreases more as grid ratio increases. Let me back up to this. So pay attention to your test questions. I don't know that I edited this question out, but there was a question, it was a critical thinking question, that specifically asked if you use this. The wording was not exactly like this, but pay attention to what the question is asking you. So if you just add a grid and you don't do anything with your technique, your patient dose doesn't change. It's not until you increase your mass that the patient dose increases. So, it's kind of a critical thinking question, so pay attention to that on the test. Wording of the question matters. So, patient dose is going to go up because of the increase in mass. Exposure decreases more as grid ratio increases. The more lead you put in your grid, the more absorption you're going to have in the image receptor. Exposure decreases. Patient exposure is going to increase as you increase your mass to compensate for a higher ratio of grid. So it reduces scatter reaching the IR, removing photons that would otherwise create an index number that indicated lower exposure. As we increase our grid ratio, we get lower exposure to the image receptor, and our index number should indicate that if we don't adjust our technique. If we adjust our technique adequately, our index numbers should be very similar. So grid frequency, we already talked about. Lower exposure with high frequency grids, what happens to dose will compensate, it would increase. Machine phase, we just talked about. Exposure increases when changing from single phase, three phase. SID, finally we got to SID. So in our magnification, and I think this was in the previous recording, as OID increases, we can compensate for an increase in OID with an increase in SID. Remember, if let's say you have a 2-inch OID and you're taking your image at 40 inches. If your OID increases to 40 and your SID increases to 80, so that you double both of them, your magnification factor remains the same. All right, so that has nothing to do with image receptor exposure, but I just wanted to remind you of that. So as OID increases, image receptor exposure decreases. As SID increases, same thing. We've got the inverse square law, compensate with mass. OID, I don't really know why I have this in two different places. OID is air gap I bet this was supposed to be SID. Collimation we already talked about. I think it's just kind of like a cheat sheet. So let's get down here to, all right, so on your KVP questions, pay attention to the question. Generally, if I'm asking for a 15% change, I'm just asking for KVP change. If you increase your KVP by 15%, you're going to have a doubling of your image receptor exposure. If I ask you about the 15% rule, that has to do with a change in KVP with an opposite change in mass to change patient exposure and leave the image receptor exposure the way it was. So pay attention to that. Let's see, detail. With detail, sharpness reported detail versus visibility. Visibility has everything to do with scatter radiation as opposed to sharpness recorded detail, or your things like OID, SID, angulation, focal spot size, and all that. So focal spot size is what we primarily use on the machine to change our sharpness reported detail. The smaller the better. The smaller the focal spot size, the greater the sharpness reported detail. Not practical to use small focal spot size on every exposure. So small focal spot size is used, or small focal spot is used whenever we are either taking x-rays of small anatomy like fingers and toes, or if we need to see high detail like in skull and things like that. So again, fractional microfocal spots are used, fractional or special procedures, micro or memo. SID changes. As SID increases, sharpness increases. As OID decreases, sharpness increases. Visibility can be affected with changes in OID, and that's, again, your air gap. So this was on the last recording, anode angle and blur. The blur is going to be greater on the cathode end of the X-ray tube, but your intensity is also going to be greater on the cathode end of the X-ray tube. Remember the difference between umbra and penumbra. Most of the time we talk about penumbra. We don't talk about umbra quite as much, but penumbra is sharpness recorded detail. Umbra is sharpness recorded detail. Penumbra is blurriness, loss of sharpness recorded detail. Okay, so mass only affects the numbers, doesn't really affect the percentage at all. The percentage of photoelectric transmission, scatter. So the only thing that affects only numbers and not percentage of, or the thing that affects in your technique that affects numbers and not percentage of interactions would be your mass. KVP affects them both, all of it. Water-type tissues, soft tissue creates most scatter. Technical factor that controls the amount of scatter produced, that will be KVP. What beam limiting does to scatter, reduces scatter, prevents scatter from being created. So increasing beam limitation, when we increase beam limitation, we increase collimation, we make the field size smaller. So our scatter goes down. Decreasing beam limitation, decreasing collimation, opening up your collimators makes scatter go up. So what scatter does to the image, that's about visibility. It gives us an increase in density, possibly a change in contrast, a decrease in contrast. So remember, we have two different types of distortion. We've got size distortion, which is all about OID and SID. And then we've got shape distortion, which has to do with angulations. So angulation on the central ray gives us elongation. Angulation of the anatomy is going to give us foreshortening. Angulations of the image receptor will also give us elongation. So size distortion is magnification. Shape distortion is everything else, really. Elongation, foreshortening. Caused by unequal magnification, that would be shape distortion. So distortion caused by unequal magnification would be shape distortion. And then we're back to absorption blur, specific structure. I think absorption blurs, I think, is overrepresented on this review. And that's it. So we'll take a look at this on Friday. Bring your questions on Friday, and I'll try my best to answer it for you.